So, hello to all the viewers. I hope my audio and video is all good. Can you please let me know in the chat box if my audio and video is good? So I'm just waiting for your comments. Okay, right. So I think we'll start the session. So basically, this will be a very short discussion of the 10 MCQs that were asked as a part of the Monday midday quiz, a series of topic-wise quizzes being conducted in the Doc Tutorials app on every Monday, 9 p.m. So which will be followed by a discussion at 9:30 p.m. So the winner of the Monday midday quiz will win a stethoscope as a prize as well. So as I said, this is just going to be a very concise discussion. The purpose of this session is not an elaborate discussion. We'll restrict this to a very concise discussion. Okay, right. So good evening, Sanjay. Good evening. Good evening. Yeah. So let's proceed ahead with the discussion. Okay, right. Okay. So let's have a look at the first question that was asked here. Okay. So the first question asks you, which of the following has the highest risk of lymphoma among all autoimmune diseases? So please understand that there are certain autoimmune diseases that can predispose to lymphomas. For example, rheumatoid arthritis can predispose to diffuse large B-cell lymphoma. Similarly, certain other autoimmune diseases as well, but the question is specifically asking about the highest risk of lymphoma. So this is a direct line from the Harrison's textbook of internal medicine. So the answer for this question is Sjogren syndrome. So Sjogren syndrome patients have an increased risk of developing malt lymphoma, which is the mucosa-associated lymphoid tissue. And among all autoimmune diseases, Sjogren syndrome has highest risk of lymphoma. Yeah, good evening, Matthew, Tarunya, Pavan. Yeah, so I hope this question is a simple one, right? So just let me know in the comment section as well how much you have scored. Sanjay, Tarunya, Matthew, Naveen, Pavan, Akshaya, please let me know how many you have got right in the Monday midday quiz. So the second question is regarding the X-ray staging system for sarcoidosis. So what is this CADing staging? This is basically a staging system of sarcoidosis. It is not a clinical staging system. This is a chest X-ray based staging system, X-ray based. And this staging system has 4 stages, stage 1, stage 2, stage 3, and stage 4, because lung involvement is very common with sarcoidosis. So in case of stage 1, the patient has infiltrates alone. So patient will be having, sorry, not infiltrates. Stage 1, the patient will be having bilateral hilar lymphadenopathy. Okay, stage 1, bilateral hilar lymphadenopathy. That is what happens in stage 1. Okay. Stage 2 of scadding is where the patient is having lymphadenopathy, just like stage 1. But in addition to the lymphadenopathy, patient is also having pulmonary infiltrates. Patient is also having pulmonary infiltrates. That is stage 2. So what is stage 3? Stage 3 is slightly more advanced. So you know that lymphadenopathy usually happens when there is an active inflammation. So in the later stages, what happens is the lymphadenopathy goes off and the patient has only infiltrates. Okay, only infiltrates without lymphadenopathy. Only infiltrates without lymphadenopathy. So this lymphadenopathy means it is a hilar lymphadenopathy. Okay, not a peripheral lymphadenopathy. Then the last stage is stage 4, which is again an advanced stage wherein you will have extensive fibrosis involving the lung parenchyma. Extensive fibrosis. Okay, right. So I can see that Lakshmi has got 7 right, Tarunya 6, Gaurav has got 8 correct, Akshaya 7. Okay, right. So Amal Maria George, excellent. You have got 9 correct, excellent. So here they have asked about The staging system characterized by both adenopathy and infiltrates. So hilar lymphadenopathy and infiltrates together, you are having it in stage 2. So the answer is stage 2 here. Third is, which of the following is a feature of eosinophilic fasciitis? So what do you think is this condition? So this is basically a question that was asked a few years back in INICT. So I just wanted to give you that question and to see how many of you would answer. So basically, why have I asked this question in this module of Monday midday is because this eosinophilic fasciitis is also another condition that can produce skin thickening, just like systemic sclerosis. We know that systemic sclerosis can have skin thickening. Similarly, eosinophilic fasciitis also can have skin thickening. But the difference between systemic sclerosis and eosinophilic fasciitis is eosinophilic fasciitis does not have any sort of a systemic involvement. So you're not going to have any sort of Raynaud's phenomenon in eosinophilic fasciitis. You're not going to have any sort of antibodies, not just anti-syndrome here. You're not going to have antibodies, and you are not going to have internal organ involvement. So the basic difference is here there will be skin induration or skin thickening, but without Raynaud's phenomenon, without any autoantibodies, and without any organ involvement, and the skin will have the so-called pudgy orange appearance. The skin in case of eosinophilic fasciitis will have pudgy orange appearance. So answer is option C. Okay, right. Let's go to the next question. True statement regarding autoantibodies in systemic sclerosis. Option A, anti-SCL70 antibodies are associated with increased risk of ILD. Second question, ANA is positive in almost all patients. Third option, anti-centromere antibodies are positive in CREST syndrome. And the last option is all the above. So the first option, yes, anti-SCL70 antibodies, they are associated with increased risk of interstitial lung disease is a correct statement. Okay, so first statement is correct. Shall I go for that as the answer? Well, there is an option all the above, so I'll have to just check out the other options. The second option says ANA is positive in almost all patients. Well, this is also true, and this is also an exact line from Harrison, because the anti-nuclear antibody, we know that it is closely associated with SLE, but we know that diseases other than SLE may also have a positive anti-nuclear antibody. And even in systemic sclerosis, majority of the patients will be having a positive anti-nuclear antibody. So this is also a true statement. The next statement is anti-centromere antibodies are positive in CREST syndrome. Well, this is also correct because basically CREST syndrome is a variant of limited cutaneous systemic sclerosis. So CREST syndrome is actually a variant of limited cutaneous systemic sclerosis. And we know that anti-centromere antibodies are associated with limited cutaneous systemic sclerosis, whereas the anti-SCL70 and anti-RNA polymerase 3, they are associated with the diffuse cutaneous systemic sclerosis. Okay, so the answer is all the above. So please mark the answer as all the above. Let me just give you one additional point. See, just like as I said, anti-SCL70 is associated with interstitial lung disease. Please also understand that the anti-RNA polymerase 3 is associated with what? Can somebody tell me? Dr. Ram Ganesh, Dr. Akshaya, can you tell me? Anti-RNA polymerase 3 is associated with what? It is associated with number one, renal involvement. There is one more additional point. Can you tell me? Anti-RNA polymerase 3, number one, it is associated with renal involvement. Number two, it is also associated with malignancy. So patients with systemic sclerosis may have an increased risk of malignancy, especially if you are having an anti-RNA polymerase 3 positivity. So the answer for this is option D, all the above. Okay, right. Now coming to the fifth question, false statement about Sjogren syndrome, more common in females. This is a true statement. Cutaneous palpable purpura. What do you think? Can Sjogren syndrome have a cutaneous palpable purpura? It is possible because Sjogren syndrome can lead on to a secondary vasculitis. So because it can lead on to a secondary vasculitis, it can very well produce a palpable purpura. So this statement is also true. The third statement is salivary gland enlargement is more common in secondary Sjogren's than in primary. So basically, Sjogren syndrome is of two types, primary Sjogren syndrome and secondary Sjogren syndrome. So primary Sjogren syndrome, primary and secondary. Primary Sjogren syndrome is mostly idiopathic, whereas secondary Sjogren syndrome occurs in association with patients having rheumatoid arthritis or maybe even sometimes SLE as well. But remember, the salivary gland enlargement, it is usually more associated with the primary Raynaud's phenomenon, primary Sjogren syndrome rather than secondary Sjogren syndrome. So this statement is actually a false statement because the salivary gland enlargement is more common in primary Sjogren syndrome than secondary. Marked lymphoma can occur is also a true statement. So the answer, the false statement is option C. So I think you're clear so far. Okay, so just let me know in the comment section if things are going good and you are following this as well. Okay, right. So let's go to the next one. The next question is about serum angiotensin converting enzyme levels, which is often repeated in your entrance exams. So they are asking elevated serum angiotensin converting enzyme levels are seen in sarcoidosis, Gaucher's disease, hyperthyroidism, and all the above. So first of all, you've got to understand that in most patients with sarcoidosis, serum angiotensin converting enzyme is elevated. And even in routine practice for patients with suspected sarcoidosis, you will be doing a serum level of angiotensin converting enzyme. But please understand that this serum angiotensin converting enzyme levels is not very specific for sarcoidosis. You can have other conditions as well, wherein you will have elevated serum angiotensin converting enzyme levels, which includes Gaucher's disease, hyperthyroidism, sometimes even Hansen's disease as well. So here the answer is going to be option D, all the above. Okay, that's clear. Let's go to the next question. Exocrine gland infiltrates in Sjogren syndrome is predominantly composed of. So basically, in case of Sjogren syndrome, you've got to understand that there is infiltration of the salivary glands, lacrimal glands by lymphocytes. So it's not neutrophils, so you can straight away eliminate option A, neutrophils. It's lymphocytes. And what sort of lymphocytes? So if you ask me about the disease pathogenesis, it is mostly the T cells which are directly involved in causing the damage to the exocrine glands. So the infiltration is mainly by the T lymphocytes. Is there any B cell hyperactivity? Yes, there is a B cell hyperactivity, but the gland infiltration is mainly by the T cells. But this question is going a step further and asking you what type of T cells. Is it the CD8 T cells or the CD4 T cells? Answer is CD4 T cells, and the answer is option D. Okay, so I hope that is also clear. Okay, right. Coming to the eighth question. So 66-year-old woman presents to the emergency room with confusion and headache. Blood pressure is pretty much elevated, 220 on 116 millimeter mercury. Physical examination is notable for skin thickening of the arms and legs, facial telangiectasias, and decreased oral aperture. Laboratory studies shows a creatinine of 3.5 milligram per deciliter. What is the most appropriate initial treatment? So the setting is that of a female who is in her 60s, and she is having some skin manifestations, that is a skin thickening. But it's not just confined to the skin. There is facial telangiectasia and oral aperture is decreased. So the context is that of a likely systemic sclerosis with a high blood pressure. So when you have got a very high blood pressure in the context of systemic sclerosis and also a renal impairment, you should think of a scleroderma renal crisis. You should think of the entity Scleroderma renal crisis. So many years back, Scleroderma renal crisis used to be the most common cause of death in patients with systemic sclerosis. But ever since it was found that ACE inhibitors, angiotensin converting enzyme inhibitors, they are useful in the management of Scleroderma renal crisis. The mortality due to Scleroderma renal crisis has come down. So if you look at the options, what is going to be the initial treatment? It is an ACE inhibitor like captopril. Okay, so just let me know in the comment section. Tarunya, Akshaya, Ram Ganesh, Lakshmi, if it is clear so far, please give me a thumbs up. Question number 9, not a common manifestation of systemic sclerosis. Not a common manifestation. Okay, right. So Moskov facial appearance is correct. Moskov or mask-like facial appearance is a manifestation of systemic sclerosis. GAVE, which is gastric antral vascular ectasia, is a manifestation of systemic sclerosis. Secondary Raynaud's phenomenon is a manifestation of systemic sclerosis. The last one, anterior uveitis, can rarely happen in systemic sclerosis, but it is not a common manifestation. Ocular manifestations are relatively less common in case of systemic sclerosis, and you have got to pick this as option C, anterior uveitis, which is not a common manifestation of systemic sclerosis. Coming to the last question of the quiz, which of the following may be useful in the treatment of patients with systemic sclerosis? Is it bosentan, riociguat, cyclophosphamide, and all the above? Okay, so see, the first option says bosentan. Bosentan, what is it? Bosentan is actually an endothelin-1 receptor antagonist. Endothelin-1 receptor antagonist is bosentan. Endothelin-1 receptor antagonist is bosentan. And riociguat is a guanyl cyclase stimulator. Guanyl cyclase stimulator. Guanyl cyclase stimulator. So both of them are effective for pulmonary arterial hypertension. Bosentan is also useful in the management of Raynaud's phenomenon as well. But pulmonary arterial hypertension, these are useful. Management of PAH, pulmonary arterial hypertension. Bosentan is useful. Riociguat is useful. Cyclophosphamide is useful in case of lung involvement, that is interstitial lung disease that can be caused by systemic sclerosis. You can use cyclophosphamide, and the answer hence is all the above. You can use all of them. So bosentan and riociguat for the treatment of pulmonary arterial hypertension. And we know that calcium channel blockers can be used in the management of Raynaud's phenomenon. Sildenafil phosphodiesterase 5 inhibitor can be used in the management of Raynaud's phenomenon. Phosphodiesterase 5 inhibitor can also be used in the management of pulmonary arterial hypertension. Okay, right. So that's it. These are the questions of the Monday midday exam series. So I hope the exam was useful in giving you an opportunity to revise a few topics in a short span of time. And yeah, as somebody asked in the comment section, well, I'm just going for a very short discussion. So this is not a detailed test and discussion or so, because time is valuable for everyone. So this is just a mini test, so which will only require a mini discussion. So stay tuned for the next Monday midday exam. So we'll see you later. The next discussion that happens on the next Monday. Okay. Thank you so much, everyone, for joining. Tarunya, Amal, Aditya, Akshaya, Lakshmi, Ram Ganesh. Thank you, everyone, for joining, and see you next week. Thank you so much.